Good morning. This is Tuesday, February 17, 2026. The full Insurance Committee of the Tennessee House of Representatives of the 114th General Assembly is now called to order. Madam Clerk, please, members do please remember to sign in and please open the roll. Madam Clerk, please take the roll.
Mr. Chairman, you have 10 members present. You have a quorum.
Barely, thank you. We have two items on our legislative agenda and bills, and we have a presentation about PBMs. Members, do we have any personal orders? We should welcome Representative Scarborough back. All right, glad you are in good health. Our first bill on the agenda is House Bill 1741. Representative Davis, you're recognized. We have a motion and we have a second.
Thank you, Mr. Chairman. I have an amendment to add to this bill. It's drafting code 013455.
Yes, that's what we have. We have a motion to attach the amendment to the bill, and we have a second. So all those in favor for attaching amendment 013455 to House Bill 1741, please say aye. Opposed? The amendment goes on the bill. Kindly explain the amended bill to us.
Thank you, Mr. Chairman, and thank you, members. The amendment spoke to the Department of Corrections, and we wanted to make sure that we had accurate language within the bill because they have a formula and a formulary instead of how, in quote, insurance. And so we wanted to make sure that we were very accurate in that legislation. But what I wanted to talk about was the fact that over several years, we've successfully, unanimously passed legislation that has to deal with non-opioid pain medication as alternatives to pain. We know the destructive cause that opioids have caused our communities and our families and so many. And so we want to ensure that everyone has an opportunity and the availability to make sure that they're aware of those non-opioid alternatives. And this allows that to be done in the prison system to make sure that they're put on that preferred drug list. And so with that, I stand ready for any questions and I ask for a favorable response.
Thank you. Members, do we have any questions? Seeing none, we are voting on House Bill 1741. All those in favor, please say aye. Oh, okay. Let's do the new-fashioned way. Madam Clerk, please take the vote.
Mr. Chairman, you have 12 ayes, 0 nays.
Thank you. Congratulations.
Thank you, Chairman. Thank you, committee.
Bill moves on to calendar and rules. Next item on our agenda is number 2, House Bill 0406. We have a motion and a second. And Chairman Martin, you're recognized.
Thank you, Chairman. I have an amendment with this bill as well.
I have 01218.
That is correct.
Okay. We have a motion and a second to adopt amendment 012018 to House Bill 0406. All those in favor, please say aye. Aye. Opposed? The amendment goes on the bill. Kindly explain your amended bill to us.
Thank you, Chair and Committee. House Bill 406 legislation ensures children and young adults 21 and under have access to medically appropriate prosthetic and custom orthotic devices through their private insurance without discrimination. This applies to private health insurance plans renewed in Tennessee on or after July 1st, 2026. Individuals 21 years of age and younger would qualify for that. This bill matters because children grow, and when they grow, children relies on this prosthetic or orthotic device. Their medical needs change frequently as their body develops. Unfortunately, current insurance practices often fail in this regard as reality sets in. Many plans cover only the basic mobility devices, denying coverage for devices needed for everyday activities like showering and swimming, and impose replacement timelines that simply do not align with that child's growth throughout that process. This bill establishes a clear and reasonable coverage standard. Importantly, it ensures coverage for devices needed not only for basic mobility, but for activities of daily living, including running, swimming, cycling, and participation. So a basic way for you guys to think about this in my regard, if an individual gets injured, shows up in my clinic, my job is to return him back to maximum medical improvement. So if you tear your ACL, we get him back maximum. Insurance covers that completely. For these children and such, if they happen to lose a limb or become disabled, currently insurers do cover the basic portion of that orthotic, but not necessarily to get them back to the maximum medical they were previously before the injury. So all this bill would do is allow that component to help work more with those children through that process as they grow and develop. And with that, I stand ready for question.
Thank you. We do have a gentleman who has signed up to testify, Mr. Warren Wells. Kindly pull the mic towards you and state your name and who you are with, and you have 3 minutes.
Thank you, Chairman and Committee. I'm Warren Wells.
Excuse me, housekeeping, we have to go out of session. Okay, now go ahead.
Thank you. I am Warren Wells, and I represent the Tennessee Partnership for Affordable Healthcare. Thank you for this opportunity to speak today. TIPA, we advocate for the fiscally responsible health policy that protects small businesses, large employers, nonprofits, and consumers from escalating healthcare costs. We recognize that ultimately the employers and the employees are the payers in our system. I do want to start with being very clear. You know, everyone in this room wants individuals who need prosthetics and custom orthotics devices to have the appropriate care. The question is, you know, who pays for that? And what is it going to cost our employers and our employees? So this bill expands the benefit mandate beyond many of what most employer-sponsored plans cover as of right now. So in Tennessee, as you all know, majority of us are covered by private sponsored plans. And when you add new mandates to that and increase those costs, you know, the employers really don't have much option, but you pay more in the premiums or deduct more from their employees, or just they may be forced to not provide that coverage, especially as small businesses. So with each mandate, we look at it, it's very narrow, but as it accumulates, it really puts a lot of pressure on premiums as they continue to grow. So, and those costs do not remain isolated to insurance companies. It is passed on to those employers in next year's premiums. So at the time when employers are already struggling with rising healthcare costs, inflation, and all the things that we're hearing about it in our economy, we must weigh the benefits for the whole group. And so thank you for your time and your consideration.
Thank you. Members, do we have any questions for Mr. Wells? Well, kindly explain to us what you think the financial impact will be of this legislation on employers.
Yeah, so I can't tell you exactly. I don't have an actuary that works for us, but I know if you look at the fiscal note, I think there's a pretty heavy fiscal note there. And so I think you could derive what that would cost our employers as well.
I understand that there would be cost to this, and the cost would come to the employers, and employers will make a decision how much they want to cover and how much they might pass on to their insured members.
Mm-hmm.
But isn't that the purpose of society, to spread the cost when individuals can't afford it?
Yeah, I think so. I mean, I think it's the same thing you guys consider whenever you're thinking about a new tax on a new industry. You have to weigh the benefit versus what it's going to cost the citizens. So I think this is very similar. Every mandate, though small at one time, will accumulate.
Thank you. Any other questions? Oh, Representative Freeman, you're recognized.
Thank you. I guess I just want to understand. So your objection is not giving people the highest quality of care because it's going to cost us more money? Is that what you're saying?
I mean, yeah, that's a great way to put it, but
Okay.
it's
So
more.
to that point, I guess it's somewhat insulting to talk to us about highest quality of care when we've got a bill in front of us that's going to do that. I mean, why don't you come up here and advocate for reducing coverage as well, if that's what you're talking about?
Yeah, I don't think that's what I'm saying. So, I mean, we can't pay for everything. I mean, it's a part of the way our society is built. It's the same with taxes. I mean, we can't give everybody free housing, can't give everybody free healthcare. Otherwise, it would crumble. You can't afford it. And so I realize that you're saying that this mandate is not that expensive, but as it accumulates, it will get out to where employers can no longer provide for their employees. They want to provide for their employees.
I guess I just completely disagree, but thank you for your comments and fighting against the people.
Thank you, Representative Freeman. Chairman Hale, you're recognized.
Thank you, Chairman. You mentioned the fiscal, and when I look at this, you know, there's a state expenditure, but I think to what you're trying to say, it would be like 1% of their total premium increase. Well, if they're paying $1,000, that's only $10 a month. But do you not think that for these people that need prosthetics to have some kind of a normalcy of life, and you're wanting to talk about dollars and cents to people's ability to do things that other people do because of losing a limb or whatever? I mean,
Yeah, but again, I'll go back to what I said. It's how it accumulates. Eventually, if we keep adding these, then those people won't even have insurance at all to cover anything. They won't be provided by their employer any longer. There's only so much that an employer can take on while we see the inflationary growth of healthcare at the same time. So I don't think it's not whether or not we want people to have prosthetics or not for a quality of life. I mean, most insurance plans do provide prosthetics, just not at this level.
Chairman Hale.
so you're wanting to tell them what results in a quality of life for them. You know, we get to the point, and one of my colleagues mentioned this a couple of weeks ago, when it comes to insurances and stuff, we start removing the human element out of it. And this is totally removing the human element out of it and thinking about these individuals that's suffering from a loss already, and then we want to limit what they're able to be. I don't think that's what we're here to do, and I would hope that that's not why you're sitting there advocating, as it appears to be. So I'm glad to support this bill for people to be able to have the best life that they can here in the state of Tennessee. Thank you, Chairman.
Mr. Wells, you have anything to say?
No, I mean, again, it just goes back to eventually the growth is going to go so much that they're not going to be able to provide for their employees. It's not a one-off whether we want to do quality of life for this certain segment of the population or not.
Chairman Terry, you're recognized.
All right. Thank you, and appreciate you come talking. And I do understand what the point that you're trying to make, but a lot of times when we have these discussions, one thing that we talk about on the front end is the fiscal note, and we look at what it's going to cost on the front end, but oftentimes we don't factor into those decisions things that it actually can save on the back end, or the production that can occur on the back end. And so when you're actually getting the prosthetic or custom orthotic that has the most recent version of evidence-based treatment, you're maximizing that ability for that individual, which makes them more productive, which in the end is likely going to pay for itself in spades on the back end, which actually could lower our costs. And so I think those are things that we need to think about, not just the human element that we're talking about, but the productivity that and the enhancement of that person's life, who can enhance all of Tennessee based on what they potentially could do with these devices. And so I'm happy to support the bill.
Thank you. Ms. Wells? Any other members' questions? If not, we'll go back into session. Do we have a Chairman Spicky, you're recognized.
Thank you, Mr. Chair. Move previous question.
Previous question is called. Madam Clerk, please open the vote. Members vote green or red. Please count the vote.
Mr. Chairman, you have 14 ayes, no nays.
Okay. House Bill 0406 moves on to Government Operations Committee. Thank you. We have presentation as our next order of business. This is to discuss the PBM laws update in light of the recent Arkansas bill. We have Mr. Michael Power and Johnny Garcia. Kindly take a seat, pull the mic towards you, and identify yourself and tell us who you're with. I thought I did. Okay, we are out of session. Thank you.
All right, Mr. Chairman, members of the committee, my name is Michael Power, and I'm with the Pharmaceutical Care Management Association. We are the national trade organization who represents the pharmacy benefit managers. And today we are going to be here to discuss the legislation that recently passed in Arkansas and the impact that it's having there and sort of where we are sit in the process. We additionally do want to discuss some impacts that could occur here in Tennessee as it relates to similar bills that have been introduced both in the House and the Senate related to a very similar issue. But before we get into that, I'd like to turn to my colleague, Dr. Johnny Garcia, to introduce himself.
Your mic is on.
Oh, it is.
When
Okay.
it's red, it's on.
Thank you, Mr. Chairman and members of the committee. My name is Johnny Garcia. I'm a pharmacist. I've worked in retail, mail order, and specialty pharmacies for the last 20 years. I'm concerned about the bill that has passed in Arkansas and hope to shed some light on what could happen in Tennessee if specialty pharmacies are not allowed to ship prescriptions into the state.
All right, thank you. So again, thank you for the opportunity to be here today. This is a very important topic, and I think to some of the discussion that was just held on the previous bill, this issue is one that does stand to have a real impact in a negative way to patients in Tennessee. And so we want to make sure we fully educate this committee on this issue so that you fully understand what the impacts can be. So as it relates to Arkansas, last year, Arkansas Act 624 was passed and signed into law by the governor. The legislation was written nearly identical to the bills that you have before you in House Bill 1959 as well as Senate Bill 2040. As the legislation moved through the process, there was a lot of opposition raised, not just by the PBM industry, but also impacted constituencies that would see things like their specialty pharmacy, mail service pharmacy, or even some brick and mortar pharmacies go away. After the legislation was signed into law, there were many plaintiffs who filed suit against the enforcement of the legislation. A federal judge enjoined those cases and delayed enforcement of the legislation. So as it sits today, Arkansas Act 624 is not being enforced for two primary reasons. The federal judge determined that there could be some impact to the TRICARE program, which is a federally administered program on behalf of veterans and those beneficiaries. And so he had some concerns over how this legislation would impact that program, as well as the constitutionality of the issue and how it may impair or may infringe upon the Commerce Clause. And so where we sit today is the state has appealed that injunction by the federal judge, and we are waiting for the Eighth Circuit to respond for oral proceedings to move forward on that legislation. So as it sits today, there's only been one state that has adopted similar legislation, and it is currently being upheld in the court systems. And so if Tennessee were to continue to move forward with this legislation, we would be somewhat on an island here. The next two slides have some data that we pulled from our member companies, and this data is specific to the PBM industry. So this does not include other players in the prescription drug supply chain, like Cardinal Healthcare, who's a wholesaler who has a PBM relationship and a pharmacy relationship, or Kroger, who is a grocery store, but also has a PBM relationship and obviously a pharmacy relationship, and then Walgreens. And so we think the impacts here are sort of conservative because it is based on the members of our organization and our organization alone. So what we see is you have roughly a little over 45,000 military service members and veterans who could be impacted through the TRICARE program if this legislation is to pass. You have about 500,000 beneficiaries who receive their prescription medications through mail service pharmacy. And there's a number of reasons that they choose to do that. They could be in an underserved area. They could have problems going to pick up their medication. There could be a variety of reasons why they prefer the use of a mail service pharmacy over other options. There's about 1.2 million prescriptions that are filled annually that are for specialty drugs. And those are patients with chronic conditions like cancer, MS, and other situations. And then lastly, if this legislation is to pass, you'll see about 142 brick and mortar retail pharmacies close. So those are the standalone retail pharmacies in the chain space. But that number builds. And so if we were to apply this legislation as it is written today, you'll have about 168 pharmacies that will close. And again, this is information from PBMs and our members at PCMA. This does not include Kroger's 114 locations or how many locations Walgreens has, et cetera. And so these 168 pharmacies are specialty pharmacies, which there's 2 here in the state, as well as mail service pharmacies. And then any employer who might have chose to offer an on-site pharmacy for their employees so that they can pick up their prescriptions on site where they work, this would impact those relationships as well. And so as it relates to the PBM workforce, you'll see about 8,000 employees and conservatively be put out of work if this legislation is to pass. This slide here is from a professor in Arkansas, at the University of Arkansas, Dr. Bai. He did an analysis last year in the wake of the legislation passing. And what he did is he modeled the PBM affiliate pharmacy relationship and determined what the value savings was to plan sponsors if that was to go away. So he modeled what the savings derived were from that relationship, and then the 744 million reflects sort of the loss in those savings to plan sponsors, patients, and even the state of Tennessee, because this law would apply to all plan types if those pharmacies are to close. And then additionally, we estimate about 880 additional hospitalizations will occur in 1 year. And that's largely based off a JAMA study that, I'm sorry, Mr. Chairman.
Kind of go back to the previous slide. You told us what the effects will be. Can you explain the mechanism of those? How will that happen? What will cause that?
The methodology or so if the way this legislation is written, it says that a PBM or any entity that has sort of a financial relationship or tied to a PBM cannot hold a pharmacy license in the state of Tennessee. And so if that is to go into effect, any one of those entities that have that business relationship could no longer operate in the state.
All right, I'm sorry to interrupt you.
No,
We'll
thank you.
Catch the questions later.
No, I appreciate the question. Sorry. So this information here is based off a JAMA study from 2024 where they looked at patients that need anti-seizure medications. And so this was specifically to that group of individuals who take these anti-seizure medicines, like my nephew. And they saw that 1 in 6 patients would stop taking their medications if there wasn't a loss of access or an issue with their pharmacy location going away. And so I think that's important to note, and that helps build that 880 number we had on the previous slide. A lot of words on this slide. I'll sort of talk briefly. So plan sponsors and patients choose mail order pharmacies or specialty pharmacies for several reasons. As it relates to mail, I touched on this earlier. They may be in an underserved area or an area where there's not a lot of access to pharmacies. And so simply receiving those medications via mail is the easiest way. They may not have access to transportation. And so getting these products shipped to their house is the best way for them to do it. And then lastly, we have veterans in this community and all across the country who do prefer having their medication shipped to their house. And so if that option goes away, per this legislation, they will have to go pick up those drugs. Specialty pharmacies, these offer 24 hours, 7 days a week wraparound services. So these are open on the weekend. They provide counseling and care to patients who are taking these complex treatments. They even, if a patient can't go to a setting to get their medication that they need, they will come to them. And so a lot of these services that you hear on the slide will be impaired if this legislation were to pass. And then lastly, before I hand it over to my colleague, Dr. Garcia, this is sort of the impact on the mail order prescription pharmacy market in Tennessee. So close to 500,000 patients today receive their medications through mail service pharmacy today. Of that population, you have about 45,000 military service members who would be at risk at losing this benefit through the TRICARE program if a judge is not to intervene like they did in Arkansas. And then lastly, if you are to restrict or eliminate mail or specialty pharmacy operations, you could see an impact over the next 10 years, about $468 million to plan sponsors, the state of Tennessee, and the beneficiaries of those plans. So with that, I'll turn it over to Mr. Garcia.
Thank you, Michael, Mr. Chairman. So I want to start off a little bit with how mail order specialty pharmacies impact my personal life. So growing up, my grandparents were on many medications. That's partly why I went to pharmacy school. It's so that I could help them understand the medications they were on. My grandparents lived in a very rural town, about 30 miles away from the closest town that had a pharmacy. They didn't have a grocery store. They didn't have a gas station. It was very small and rural. As my grandmother got older, she didn't have anybody to help pick up medications for her. And so I researched her health plan and her benefits and found that she could use mail order pharmacy to get the medications delivered to her home. That saved her the hassle of having to worry about refills coming to her home, not having medications because she was running low, finding somebody to go take her to get the medications or finding somebody to pick them up for her. So they were delivered directly to her house. With this bill, people in a similar situation will also be in the same issue as my grandmother. So talking a little bit about this slide here, this is why specialty pharmacy is kind of being carved out. And you're hearing so much about specialty pharmacy. The biggest takeaway from this is that 3% of the volume of prescriptions accounts for 50% of the prescription dollars in the market. So in the 90s, 2000s, before specialty drugs were starting to be developed, it was smaller. It was 85% for generic drugs for volume, but only 15% of the cost now. So specialty drugs are very expensive. So PBMs are looking for ways to reduce the cost of specialty drugs because it is a driver in the healthcare space. So one more stat here before I go into what a specialty pharmacy actually does to help get these prescriptions out the door. So there's approximately 1.2 million prescriptions that are filled by specialty pharmacies for residents in Tennessee. About 215,000 patients use specialty pharmacies to get these medications. And there's about a $2.8 billion savings over the next 10 years through the use of specialty pharmacy. So there's about 7 steps that go into this. If you've ever gone into a retail pharmacy and watched the pharmacist work behind the counter, the prescription comes in, technician or somebody types the prescription, bills the insurance, they get the copay and all the paperwork, labels and everything that go on the box. They label the box, pharmacist checks it, make sure there's no interactions, goes out to the patient, and then the pharmacist may or may not counsel the patient depending on the type of medication. Specialty pharmacy is a lot different than that. There's 7 very detailed steps that are conducted by specialized groups of people. So when the initial prescription comes in, it goes through benefits verification. That I'll go into that a little bit more further, but it's basically checking to see what is the lowest cost for the patient, whether it's using medical benefits or looking at the prescription benefits, financial assistance programs, coupons, all of that goes into the benefits verification. So it's looking for the cheapest way to get that prescription out the door. Then it goes into a clinical assessment. That's where your pharmacist will look at all the paperwork before them, partnering with the doctors to make sure that we have everything that we need, looking at lab work, liver tests, kidney tests, patient weight, specifically in cancer patients, where weight is very important to these types of medications. If the patient's lost weight, we got to adjust the dose. We need to let the doctor know that the dose needs to be adjusted. That's a very critical step to ensuring the safety of the patient. Care coordination, this is working with the health experts that the patient is seeing to make sure that we're getting the medication to them on time, making sure that we have nurses on staff if we need them, going to their homes, whatever we need to do to help the patient get the medication here. Education and support, this is where we contact the patient and walk them through what they can expect when the prescription is being administered. So this is also the time where the patient can let us know when they have concerns. They may not have a ride to the doctor's office. Specialty pharmacies absolutely do use transportation services to help patients get these medications. This is where they step in and go beyond the traditional pharmacy model. After that, patient gives us the approval to dispense the medication, we dispense it and we bill it. So all of these steps occur before we even collect payment. So diving a little bit further into this, it's a high touch, as you can tell, based on the previous slide. They have 24/7 access to pharmacists. They can call at any time if they have questions. The physician consultation, making sure that we're partnering with the physicians and the doctor's offices to make sure the patient's getting optimal therapy here. Proactive outreach for refills and care. Some patients forget that they have a refill due or that the medication was administered once a month, so they don't realize they need some time in there. So we'll contact them when the plan allows, usually about 23 days before the 30-day mark or 60 days before the 90-day mark if it's a 90-day prescription to help them get the medications on time. Financial assistance. This will be lost for the patients here in Tennessee. The financial assistance is a key thing of the specialty pharmacies. We look at all the foundational assistance programs. Sometimes they're through the drug manufacturers to get those drugs out the door. Sometimes it's through the PBM or through the mail order pharmacy. They have programs there to reduce that, coupons, those type of things. They have access to that through the health plan. The medication management, staying on the drug adherence, as my colleague Michael said, 1 in 6 will fall off the medications because of legislation like this. They will not know how to get the medication. They will not know how to get it to another pharmacy. They may not be able to access the medication just going to the doctor's office. Coordinating administration services. Some of the patients in specialty pharmacies require infusion services. Specifically in COVID, we had a lot of patients who did not want to go into a hospital to receive the medications. So we coordinated with a home infusion service to come to the patient's house and administer the drugs in the comfort of their own home. And then care coordination, as we talked about, this is using the medical and pharmacy benefits, looking at the patient holistically, trying to find out what's the cheapest way to do it. Quality control measures, specialty pharmacies. If you've never stepped into one, I encourage you to come see some of the ones that we have in the state. They're very sophisticated processes, lots of robotics, lots of checks. You don't have a phone ringing a drive-through and you're ringing the doorbell. You don't have somebody walking up to a patient consultation. The pharmacist and the team that's handling these prescriptions are very focused on the medications that they're delivering. So how are the specialty teams kind of divided? Most of the specialty pharmacies have dedicated teams to the disease states. In fact, if you look at the 10 care formulary list of specialty medications, it's divided by very similar disease states. So they are broken up by HIV, transplant medications, cancer patients, stuff like that. And these are groups of technicians and pharmacists that have been specialized in these. Some of these are students that have gone to additional education after pharmacy school to learn about how to treat a cancer patient. We employ those people. Technicians that have been specifically trained just to handle these drugs and handle these processes, handle these patients, making sure they understand the patient concerns, doing the quality of life surveys that are done every couple days after a patient starts a medication, making sure that the patient, as we heard before, is looked at holistically, not losing track of that patient and coordinating with the doctor. So with that, I would just say that this bill that is before you right now is an attack on my profession. Closing down a pharmacy or forcing a pharmacy to choose whether they're going to maintain a license or not puts aside everything that I've worked for, both personally and professionally, to make sure that patients have access to the medications that they truly do need. So with that, I'll send it back over to Michael.
Thank you. So last slide here, and then happy to take any questions, Mr. Chairman. But this is sort of a recap of some of the high-level impacts that we could anticipate if this body and this legislature is to advance House Bill 1959. And I think the three, some of the key takeaways are conservatively, 8,000 Tennesseans could lose their jobs, right? If this legislation is passed and those pharmacies need to close, including those specialty pharmacies in the western part of the state as well as in the eastern part of the state. The veteran community, they get their benefits through TRICARE. That is a national program. This legislation does not contemplate an ERISA plan, a TRICARE program, a Medicare program. It simply closes pharmacies, which impacts all patients. And so that's a vulnerable population that I think we should be thinking multiple times about before we impact them. And then lastly, this will, raise costs for patients and employers. And I think we have demonstrated that in a few of the slides, sort of where that value is derived from and that impact. And so with that, we'll be happy to take any questions that this committee has.
Well, thank you. Members, do we have questions? Chairman Sparks, you're recognized.
Well, I was waiting on some other people to ask some questions. Let me ask, I'm not an expert in this field by no means. I don't think anyone is. My late stepfather was a state investigator for the Board of Pharmacy. I wish I could pick up the phone and call him. He literally started the first Walgreens in '57 as a manager. He's no longer with us today, so I can't pick up the phone and call him. But let me ask, every time I talk to independent pharmacists, they're concerned about this area. Seems like it's eliminating the free market. Seems like PBMs are driving up cost, not lowering cost. If I'm not mistaken, and maybe Dr. Terry and some others could add to this, we've seen a lot of closures from independent pharmacies the past few years. From what I knew about economics, or learned economics, an oligopoly is three to four players, or a monopoly is one player. Is your industry not an oligopoly in the pharmaceutical industry, which is driving up cost for both Tennesseans and Americans across the nation?
You're recognized.
Thank you for the question. I think it's important to note that there are 70 full-service PBMs that operate in the country today. There is no state federal law that requires any plan sponsor, so that would be a state plan like Tennessee's program, the federal government, from using a PBM. And so through that network, about 290 million Americans today receive their prescription drugs through a PBM. And our role, and I think why there's so much controversy in our space, is to negotiate discounts with drug manufacturers. And so that creates a natural friction point there, and as well as go into the marketplace on behalf of the plan sponsors and to try to find the lowest pharmacy location, lowest price pharmacy location to get when their lives go pick up those medications. And so that's how we design those networks. So as a result of that, when you have big players that like Walmart that dispense 10% of the drugs in the marketplace, or you have grocery stores who are willing to give away, prescriptions for $0 or $2, it sort of those entities are creating the incentive and the price point by which reimbursements are set. And so now we have Amazon, Trump RX, Blink RX coming into the marketplace that will totally disrupt that marketplace even further.
Chairman Sparks?
Mark Cuban's business, I forgot the name of his company. I mean, that's not a PBM that he's created, then, is it?
It is not. It's a new market entrant. It's a disruptor.
And that disruptor has benefited the patients, hasn't it?
I can't speak to the
By
business
lower
model,
cost.
but I think there are some that have received benefits from it. But
Let me ask you, other people on this panel, a lot smarter than this than I am. Warren Wells just spoke, and I appreciate him coming up here and having the conviction to take some bullets from some folks, and because we have to control our costs. And one of the areas, I think this is an area that this state can save money. I mean, our TennCare costs are continuing to climb. Drug costs are continuing to climb. Explain the Arkansas bill. I know you went over some of it, but it just seems like we got a big problem when it comes to drug costs. I think everyone knows it. And I appreciate the chairman for having this hearing and you all coming up. But are we not the highest drug cost in the world, America?
Mr. Chairman, yeah, I agree with you. I mean, I think that's where you're seeing a lot of the PBMs and the pharmacies trying to figure out the best way to handle these. So are we the highest cost in the world? Absolutely. We have the talking point that we hear often is that the United States is the first to receive new medications. We're first to market. So we're paying for that service. So this is where PBMs come in. We're trying to negotiate these prices down. We're looking for ways to reduce it. As I showed you earlier, the cost of specialty medications account for 50% of the cost, but only 3% of the volume. That's huge. They're new. These are medications that came out starting in 2014, and it just continues to snowball from there. And it is the reason why premiums are going up.
Yep.
Chairman Sparks?
Chairman, I just want to encourage this body to stay on this topic for the rest of this session if we can. Thank you, sir.
Thank you. Chairman Lafferty, you're recognized.
Thank you, Mr. Chairman, and my apologies to the members for being late today. The comment you made a second ago, and I'm sorry I didn't get everybody's names earlier on, about 70%, and I don't remember exactly how you said it, but 70% of the market has access or is serviced by PBMs. Did I get that right?
so 290 million Americans receive their prescription drug benefit through a variety of PBMs. There's about 70 full service PBMs that operate in the marketplace.
Okay, and
Yeah.
it is my understanding from slides that we've seen in this committee in the past that only a handful of PBMs make up that 70%. Is that correct? They kind of dominate the market, I
Mr. Chairman.
guess.
Yeah, so the stat you're probably reading is that 80% of the market is controlled by 3 PBMs. That's been surfacing quite a bit. That data has been extrapolated, and the story's been kind of extrapolated as well. It's 80% of claims are processed by 3 PBMs, meaning that a pharmacy, when they're billing the insurance company, will bill the big 3 for those claims. That includes some of the smaller PBMs who do not offer claims processing. They utilize the services of the big 3 to process those claims. So it's kind of a bunch of PBMs rolled up into one, but that number's been inflated.
So just for my mind to share with my members, the more conflated all of this gets, the tougher it gets for us as legislators to sift through it. And this goes back to when I first started hearing about PBM 7 or 8 years ago. My early feeling, and this is just from accumulation of evidence over time, it started to look more and more like PBMs started out as, yes, we are this way to get involved in the process, to help cut some costs, to help patient outcomes, all those things that it was initially intended to be. It feels today like PBMs, and I could be completely off base, members. This is just Representative Lafferty speaking. Feels to me like today PBMs have found their niche and have been successfully, hidden's not the right word because there's a good bit of conversation, but they have successfully found a spot in the chain that when most products go production, retail, sale. I'm sorry, production, distribution, retail, sale. Seems like with the drug business these days, we've got a situation where we go production, distribution, PBMs, retail, sale. Can you help me square putting an extra step in between the consumer and the manufacturer, how that helps lower cost?
Go ahead.
Thank you for the question. Thank you, Mr. Chairman. So there's sort of two paths you got to break apart there. So one, with the drug manufacturer side, you then have the wholesaler and you have the end retail location, right? And so you have your three large wholesalers that control like 95% of all drugs dispensed in this country. And in that business model there, they control several steps in that process, including what is called the Pharmacy Service Administrative Organization. And they're an entity between the top three wholesalers that contract with over 17,000 pharmacies in this country. Those entities negotiate with a PBM for the price that the plan will pay for the products on the shelves at the retail pharmacy, at the independent pharmacy. That PSAO, who has a family relationship with the wholesaler, then negotiates with those independent pharmacies on those goods that they buy and put on their shelves. The PBM sort of serves the role of administering the plan as a third-party administrator on behalf of the plan sponsor. So that could be an employer, large or small, the state healthcare program, federal programs like TRICARE, and we are retained to provide a service for those entities. And so part of that is claims processing. Some of it is depending on what services that they want to have in their plan. It could be mail service pharmacy, specialty drugs, but there's about 8 different services that PBMs do provide those plan sponsors to help administer the plan on their behalf. Years ago, entities used to do this in-house, but it became such a big problem as drug utilization increased that they started to outsource it to manage this side of their benefit.
Chairman Lafferty.
Thank you. And I think this will be my last follow-up. Just a second ago, you used a term, family relationship. Is that another way of saying owned by the same and under the same corporate umbrella?
Ms. Powers?
Yes.
Thank you. Thank you, Chairman.
Thank you. You've told us the impact of the Arkansas law or similar legislation, but going back to what has caused these laws to come, be drafted or passed, do you acknowledge the inherent conflict of interest between PBMs, then pharmacies that you own that are your children, and then you have stepchildren, who the ones you don't own? There's a very straightforward conflict of interest.
Thank you for the question. And so I think the answer is, I mean, look, these mergers and acquisitions historically have been reviewed by CBO, the FTC, and now I know we live in a new world today and the FTC is looking at things a little differently, but as these companies acquired different parts of the supply chain, these were mergers and acquisitions that were approved by all levels of government. And similarly though, you have to look, if this business model in the PBM side is perverse, then so should the same must be true for hospital systems who have group purchasing organizations, for wholesalers who even own oncology centers. I mean, so we're awfully focused on one piece of the supply chain without looking at the entire ecosystem, and all we're doing is squeezing a balloon.
I'm not sure I see that, and you didn't really answer or acknowledge the conflict of interest that I was trying to say that is fairly obvious. Do you have a solution in mind, or do you want to keep with the status quo? There is a problem, right? Where certain pharmacies that are owned by PBMs are favored. They are even paid higher prices for comparable services from private small town pharmacies. So there is a problem. Do you have a proposal or a solution? Do you want to acknowledge the problem?
So over the last several years, the state of Tennessee has passed extensive PBM reform laws, including in 2021 and 2023. And we're seeing the results of those laws play out. And we're seeing the department do examinations and audits And if there are discrepancies found, that those things are being resolved. And Tennessee is right now at the front end of PBM reform with the absence of following Arkansas. Tennessee has some pretty restrictive PBM laws in the books. And the federal government took action in the last 2 weeks, largely in Medicare, but also in the commercial marketplace to ensure that there's greater transparency and rebate pass-through back to the plan sponsors. And so there is a lot happening in this space, but Tennessee has certainly been a leader in this space in regulating PBMs.
Well, thank you for the compliment. All right. Members, do we have any other questions? Seeing none, thank you for coming. We appreciate it. And it helps us understand and have a conversation about where we stand at this time, despite a lot of efforts by us. There are parts where problems still persist, and we would like to make it better, basically, to serve our citizens who need the medications. Yes, Chairman Sparks.
Chairman, is this the last time they're going to come up and speak, or we're going to have some ongoing meetings the next few weeks?
This is the last.
Okay. Well, I think we need to be asking questions. I'll encourage my comrades to ask a few questions. I mean, this is a serious issue. I don't have time to go call independent pharmacists and ask them, but I know it's a real issue for them. I know it's an issue, especially when they're closing their doors, because it's a confusing topic. It really is. Explain the PBM. How do you pronounce it? Vertical integration. Explain how that works.
Mr. Chairman.
Yeah.
All right. So vertical integration is a term that's used to talk about the alignment of different business practices. So it's surfaced when some of the major PBMs combined business practices with the health plan. And then through that, they created other branches to kind of help manage the business. A lot of this was done to help look at the patient holistically. And as by example, Kaiser Permanente, a gold standard in healthcare, more on the West Coast. But they had access to everything. They had access to the patient. They had generational access of data. Patients that have been going there, parents have been going there, grandparents have been going there. So they were able to follow those patients through. So the thought was that if they could follow the patient all the way through the entire system, there would be less chances of the patient falling through the cracks in certain areas. There's also areas of opportunity to reduce waste. So in specialty specifically, we can look at medical claims and pharmacy claims and determine which is cheaper, because the plan may be decide that the drug is cheaper through the medical side. So we have access to that kind of stuff. So that's the vertical integration. Now, some of our members have also has their chain pharmacies. They took it one step further. Not all of them do. Some do have the mail order and specialty pharmacies. Not all of them do. So, back to a question about Mark Cuban's, I believe it was yours, sir. There are some PBMs that are contracting with him because he is cheaper than they can receive other ways. So they're looking at the patient and what is the cheapest way to get it.
Well, we mentioned disruptors like Mark Cuban's business. What's the name of his company?
Cost Plus.
Cost Plus. What other disruptors are out there that's in the marketplace that's helping patients? Can you name a few others in Mark Cuban's company?
Yes, sir. I mean, there's GoodRx. They're a coupon and cash paying. So that's to see if there's an alternative that's maybe cheaper than a person who has a high deductible health plan, right? It might be cheaper for the patient to receive that. The Trump RX system is definitely a disruptor. It's too early to tell how that's going to shape the market, but it's definitely something that we're watching.
Yes.
So,
but the PBM market share is how much?
Claims processing only is 80%. I believe in terms of the services that they manage, it's somewhere around 70% of the population use the big three.
And you mentioned Walmart. What percentage is that?
Of the prescription drug retail space?
Yes, sir.
I saw a presentation a couple of years ago by their pharmacy director, and they control about 10% of the prescription drugs dispensed in this country.
Okay. Are they considered a disruptor like Mark Cuban's business as well?
I would say at one time they were. When generics were cheaper, they used to have their $4 generic list. I think we all remember that from the early 2000s. That list has dwindled from about 10 pages down to 2 because the cost of drugs have gone up. So they can't offer that anymore.
All right. Thanks, sir.
Yep.
Members, do we have any more questions? Seeing none, thank you for coming.
Thank you, Mr.
Again,
Chairman.
these conversations help us think better. We appreciate you. Thank you. All right. We'll go back into session. Any other business to come before committee? Seeing none, we stand adjourned.